included malaria rapid test, which was negative, urine dipstick, which presented with leukocytes plus, blood plus, ketone nil. Next. So we were treating this patient as HHS with sepsis. Management that was started, we started the patient on normal saline, alternating with ringalactate 2-liter bolus in over 1 hour. After an hour, the reassessment of RBG was still high. The patient was started on insulin 50 international units in 500 mils of normal saline. Ceftriaxone and metronidazole was initiated in the first 30 minutes. Catheterization was done, which revealed pus in the urine. Oxygen therapy for support because the patient was really dyspneic. Medical consultation was done and ICU consultation was done. So the agreement was the patient to be admitted in ICU. Next. So among the blood investigations that were taken, the results had white blood cells of 18.65, neutrophil of 15, lymphocytes of 1.1, hemoglobin of 8, platelet of 26, ESR of 140. His creatinine was 372 and urea of 59. Electrolytes, sodium of 131 and chloride of 105. Potassium were not out yet, the results. Next. So we also did the chest X-ray. As you can see, the patient has multiple patchy infiltration, mostly in the lower lobe, and enlarged cardiac silhouette. Next. So upon arrival at ICU, the vitals, the patient had blood pressure of 121/76, pulse rate of 89, and respiratory rate of 26, saturation of 98, and random blood glucose of 27.8. The respiratory and cardiovascular system were not significant. Per abdomen, he was tender on palpation, mostly on the lower abdomen. Central nervous system, the patient was confused with a Glasgow Coma scale of 13 and urine output of 1,100 mils. The urine dipstick at ICU, he had ketones plus, glucose and nitrites, as well as protein and leukocytes. So the management there, they continued with normal saline, 5 liters in 10 hours. Injection insulin soluble 6 international unit hourly. When RBG less than 14, they indicated that the patient should be given insulin 3 international unit hourly. Wound dressing, he was also started on IV Lasix 40 milligram. IV ceftriaxone was continued 2 gram and monitoring of vitals. Next. So the patient stayed in ICU for 4 days before he passed away. The vitals were blood pressure of 112/84, pulse rate of 86, respiratory rate of 20, temperature of 37.4, and saturation of 98. On examination, he was semi-conscious, febrile, mouth ulcer with blood stains, palmar pallor. He wasn't dyspneic and was not jaundiced. Per abdomen, septic wound that has been drained past about 30 mils, and catheter in situ urine bag draining pass. Next. So the management there, they initiated him on IV ampiclox 1 gram, IV metronidazole 500, insulin 10 international units 8 hourly, omeprazole 40 milligram, paracetamol 1 gram 8 hourly. Urine analysis and urine culture was ordered. Next. So they did a urology consult, which was done on 13th. And the urology team started him on IV ciprofloxacin 400, tramadol, mupirocin cream, and the patient was planned for incision, so they requested for routine blood as well as other investigations. Next. So the last review was done on 14th around 8 hours. Vitals, blood pressure of 88/53 with a pulse rate of 101, respiratory rate of 22, temperature of 37.4, and random blood glucose of 23.4. Saturation was 94. So around 1 p.m., death was certified. So the possible cause of death was septic shock. So next. Now for this patient, I think there are some of the things that were missing, which could have been very crucial in his management, such as the arterial blood gases and lactate, which are very important prognostic indicator. But we were not sure on when actually he started worsening before he was brought to the emergency room, probably way before, maybe 2 or 3 days. We don't know the compliance of the patient's treatment and his illness, because most of the relatives, when they were asked, they didn't know most of the things. Now, another thing that there's still a lot of comorbidities contributing to infection in Tanzania, which proves challenging in managing sepsis or septic shock due to the resistance they developed to antibiotic. Now, even for us, one thing that we didn't do was blood culture. So I think it also contributes to the resistance on whether the medication we were giving him were working, or maybe he needed something more strong. So it's open for discussion if anybody has a question.
Thank you very much for that excellent presentation. And it sounds like this patient is extremely unwell and received very good care. Gideon, I can't see if there are any hands up, but are there any hands up from the those that have joined the call?
And also from the, even from the chat, there's no, let me check the chat. I don't think there's any question there.
Okay.
Unless anyone has got a question.
Oh, there's
May I ask a question?
sure.
Yeah, sure.
Thank you for your presentation.
Thank you.
A couple of questions.
Okay.
The first part of your presentation, you mentioned the use of antibiotics in sepsis in general,
Yeah.
and you mentioned the use of I think it was ceftriaxone as empiric antibiotic.
That should be okay.
Is your choice of antibiotic completely empiric for everybody, or is it directed at the source of sepsis in each individual patient? We know that up to 70% of patients with sepsis, you will be able to identify the focus of sepsis at presentation. So do you give ceftriaxone to everybody, or do you direct your antibiotics at the source or the presumed focus of sepsis at presentation? That's the first question. And the second question is about the presentation. In the gentleman presented, he has a past history of diabetes, and he has presented with a history suggestive of an infection. And you said there was a wound in the lower abdomen. Was this a post-operative wound? Was this a traumatic wound? Was this like cellulitis or something? What was the wound? Thank you.
Okay.
Those are my questions.
Thank you for your questions. So first of all, regarding the empiric antibiotic, normally for our guideline, for every patient we suspect of sepsis, regardless of what is the cause, we start them on ceftriaxone. That changes unless blood culture culture results come differently. And number two, so for this patient, it was an abscess. It wasn't a traumatic wound. There was no previous surgery. It was just an abscess that formed lower abdomen around the at the area of the pubic area. So that's why the urology, they were planning to do incision. I think it was also so that they could also check what was the reason or the cause, if it's a fistula or something that formed.
Okay. Well, thank you for the answers. I would like to ask if you would consider, sort of directing your antibiotic therapy towards the source, because the usual spectrum of organism causing infection in the chest may be different from the urinary tract, for example. So it's just a suggestion. Thank you.
Thank you. Thank you.
Thank you. There's some questions from the chat.
Okay.
Did the patient have an HIV test and a malaria test?
Yeah, they did.
They did.
Yeah.
And I guess they were negative.
Yeah, they were negative.
Okay. And did the patient undergo a post-mortem at all, just to try and identify, or have you had any results back subsequently that have helped you identify what the source was, or what the bugs, that were at the root of this may have been?
No, the patient didn't undergo any postmortem, and we didn't find any other results. So maybe I say we didn't follow up on the results after he passed away.
Are there any other questions or any other comments? Speak now. Oh, there you go. Any abdominal imaging?
No, there was no abdominal imaging done.
Okay.
So I got a question.
Sure.
Okay.
Okay, first of all, is about what was the rationale of changing ceftriaxone to ampiclox? The second thing was about fluid administration. I've seen that after giving that bolus of 2 liters, then you decide to give 5 liters, and the patient was normotensive, except with the exception of being tachycardic.
Okay.
And what was the real rationale of giving that a lot of fluid? And we know that in sepsis, fluid is double-edged sword. So optimization of amount of fluid regarding monitoring of inferior venous cover status plus vitals and some tests, you can give a clue of either adjusting those fluid so that to avoid damage to the patient. And the last question all about the choice of vasopressors. So at the end of the day, you have seen that the patient was having hypotension before death, and the patient was receiving fluid. I think it was the right time to consider vasopressors, because if the patient was receiving fluid and then the patient was not improving, for the case of vitals, it was the right choice. And the last, sorry, I would like to ask another question about the choice of fluid. You have seen in your case, you managed using normal saline, and our current guideline, for example, surviving sepsis campaign, recommend the use of Ringer's lactate over normal salines because of some complication from normal saline, like hyperchloremic acidosis, and the ability of normal saline to rise intravascular volume compared to the Ringer's lactate it's more of Ringer's lactate. So I would like to know your point of view regarding those points I've mentioned.
Okay. I'll try to answer as the ones I remember. You remind me for the questions I forgot. But regarding the use of normal saline and Ringer lactate, while he was at emergency, we alternated Ringer lactate and normal saline, as I said earlier. Now, the management that I mentioned after was the management after he was admitted. It was the management by the medical team. Another thing you asked, why was he shifted from Ampiclox, from ceftriaxone to Ampiclox. I cannot answer to that. I'm not very sure because I wasn't there when they shifted. So maybe they felt that the patient, due to the abscess that they saw, they tried to do maybe the targeted therapy, trying to target the microbial, probably. What else?
Yeah, about 5 liters of normal saline.
The 5 liters was in 10 hours. It wasn't just in 1 hour. It was given in intervals. I don't know where the document is, but they actually gave 500 mils in 1 hour, and then after 2 hours they would give another 500. It was a duration of 10 hours, and that's why I specified there that it was 5 liters in 10 hours. It wasn't just in like within 1 or 2 hours.
Okay.
Yeah.
And okay, I would like to add something about the fluid management in sepsis.
Okay.
Of course, the patient may not present with signs of hypoperfusion and sometimes maybe hypotension, but we should be, I think, careful with the fluid because too much fluid is very dangerous to the patient, especially sepsis.
That's
So
true.
that's why we recommend the use of ultrasound, point of care ultrasound to look for inferior vena cava status so that we can optimize. Of course, for the normal patient or normal person, 10 liters, even in 10 hours, I think it is a huge amount for that person. Okay, thank you.
Thank you.
Thank you very much, Dr. Nelson. There's a couple of other themes that are appearing in the chat, and that's about hemodynamic monitoring, apart from IVC measurements. So we understand sepsis is one of those syndromes that affects all parts of the cardiovascular system. It can, it can cause vasoplegia and vasodilation. It can contribute to hypovolemia, but it can also impact the contractility of the myocardium. And often you need to have a combination tailored to the patient of vasopressors, inotropes, and fluids. And it's very difficult to get that recipe correct. And it's something that research is very much focused on, certainly going forwards. But hemodynamic monitoring, sometimes when you're trying to work out how much of a component is there of hypovolemia, how much vasoplegia that is there, and how much of it is an inotropy, a contractility problem. Sometimes hemodynamic monitoring, can help, and that can take the form of, as you said, IVC monitoring, bedside echo, but also other kind of forms of hemodynamic monitoring. And I just wanted to ask, are there any, do you have access to hemodynamic monitoring? Was it used? I'm not sure if you know the answers to that question.
I can't answer to that. I'm not very sure if they use them. Yeah.
Okay. I'm just going to have a quick look through the chat. There's some questions about, could this have been an abscess? Could this been abdominal, a collection of pus in the abdomen that was fistulating through various sources? But I understand we were unable to obtain any imaging, so maybe it's something worth considering. I think that's, apart from comments, there are no other further questions in the chat there.
There's Dr. Nasib, I think he's got his hand up.
Oh, yes. Dr. Nasibu, hi.
Hi, can you hear me?
Sure, yes.
Sorry, I mean, it's just a comment. Just want to say how close do the emergency department work with the critical care team? It looked like this was clearly a very complicated patient with so much going on. And I think having a few more, heads together could potentially make a difference. We don't know. But I think involving the critical care team area and probably the surgeons know that was involved. But I think working closer to the critical care team could be beneficial for most of the septic patients, I think. That's what I want to add. And regarding the antibiotic, I think we kind of have to understand that every area have different sensitivities and stuff. So what they use in Zanzibar is not exactly what I'm going to use in Cumbria. So I think we just have to see what is working in what locality. That's all. Thank you.
Thank you.
Absolutely, excellent comments there. Anybody else have any questions or comments?
I just want to add a comment in terms of thank you very much, Dr. Aisha, for taking time despite being very busy on call yesterday. And you've done this presentation. We are very grateful for your participation and collaborating with Queen's Hospital in London. And we're looking forward to working with you in future as well.
Thank you.
Yeah, I just wanted to echo that. Certainly an excellent presentation. And the presentation of a case that actually generated a lot of discussion and a lot of learning. So thank you very much for your time and your effort. Thank you.
Thank you.
Brilliant. Okay, we will swiftly move on to our next presentation, which is going to be from Dr. Anupam Basumatri, who's a critical care consultant with us in BHR UT. Thank you, Anupam. Over to you.
Everyone can hear me?
Yes.
Okay. Good afternoon, everyone. I'm sorry that I could join a little late, but then I shall be very prompt in sharing my slides and continue with the presentation. Can someone enable my screen sharing, please?
Yes, we have to make you a co-host. Sorry.
Sorry for that.
Yes, just give me a minute.
No problem.
Anupam, you're ready to go. You are the co-host now.
Sure. Thank you, Dr. Malawa. Yeah. Okay, everyone can see my slide, I believe. Today I'm going to present, I think, it's a very young man who unfortunately came with severe breathing difficulties. He is 37. Reportedly, he was unwell for 6 days before coming to the hospital with difficulty in breathing, coughing up with dark phlegms, concerns about hemopsis, urea getting concentrated. He has a background of bronchial asthma, but not on any regular medications. He otherwise lived alone, independent, although he has a family. He had family issues, but given all these circumstances, he used to be a heavy alcohol consumption with possibly heavy smoker, although it was mentioned as about 4 to 5. And there were history of some dyslipidemia, but on other medications. So when he came to the resus, he was immediately assessed, having spontaneous breathing, tachycardia, tachypnea. He's speaking in sentences, maintaining hemodynamics, heart rate of 110, blood pressure of 110/65. There were audible crepitations in both the chest, but no wheeze. And by the end of the bedside, he was looking very unwell, lethargic, and weak. He had some mild epileptic tenderness, but then he was still maintaining his GCS 15/15. And he had a gas done, which is the VVG. You can see here, that was done at resus with a pH of 7.4. Lactate was 4.4, which is very striking. Creatinine was 175. Subsequently, he had a blood gas arterial done, which is showing pH of 7.5 because he was hyperventilating, trying to compensate possibly for the metabolic acidosis, high lactate and creatinine. He is maintaining his PO2 with her non-limiting mask 15 liters. You can see the lactate still remains high. Let's go back. The initial bloods were showing WBCs of 1.7, which is quite low, expectedly. But remarkably, he had a platelet of 55. Creatinine, as you can see, is still high, 176. Bilirubin has risen to 44. Phosphate was low. He had an initial X-ray done, which I will show a little later, was showing bilateral significant consolidation. His COVID card test was negative. So there was a problem listed. He was labeled as having bilateral community acquired pneumonia. He came positive for pneumococcal antigen. I think this report didn't come at resus. It came later, but I've added it here so that I didn't miss it. But as you can see, he has gone into multi-organ failure with severe thrombocytopenia, hyperlipidemia, acute kidney injury. Some of the bloods I just wanted to show to our here again, it confirms the platelet. Subsequently, his clottings are normal. But I know this is a little busy slide. But again, I would like to point out that his urea creatinine is very high. You can see the bilirubin is high as well. And to look at the infection markers, inflammatory markers, you can see the CRP is very high at about 305. And the procalcitonin is also very high at 4.7, coming up to 4.5. And this is one of the very early graphs that I could gather. His lactate movement, it went to as high as nearly 10 at one point. It's clearly showing that there is quite a massive underlying sepsis and organ dysregulation. So this gentleman was immediately escalated for ITU assessment. Our team took over the patients, brought him to the ITU. He was immediately started on high flow nasal cannula oxygen. He was started on antibiotics, even in the A&E standard because of chest infections, Comoxiclav, clarithromycin, and he was also administered a stat dose of amikacin as well. Before that, septic screen as standard, we follow the sepsis 6 pathway. So the septic screen and the bloods were sent. In the ITU, we set up the hemodynamic monitoring, including arterial lines, central lines. But then he did not tolerate high flow nasal cannula oxygen for too long. So he had to be promptly intubated, ventilated, I think within 3 to 4 hours. Volume control, mode, with a tidal volume around 430. PEEP quickly went up to 8 to 10. Respiratory rate had to be around 22. FI2 was still at about 0.7 after a certain time. He was sedated and also paralyzed. He required vasopressors to begin with. It slowly crept up to 0.23 as a mix of sepsis plus sedation. We didn't have to give too much of fluid boluses because we were a little reluctant to give more fluid boluses given the fact that his chest is so congested. We gave maintenance doses. Normally, we put the NG during the intubations, and he was promptly started on NG feed at a slow start. But later on, he had to be probed for 2 sessions, I think, on the day of admission, and then also on the day of second day of admissions. So this is the initial X-ray, which was done in the resus. You can see clearly there are bilateral infiltrates more on the left. Subsequently, even in the ITU, it was looking just like more enhanced patches, consolidations. We also had the opportunity to do a CT scan. This was on the second day of admission. You can look at the CT scan. It's again the bilateral infiltrates, quite a dense consolidations, patchy on the left and right. So he was not getting any better actually, despite the proning, because in the sense he looked like initially he responded to proning. FiO2 came down to 0.6, but then on subsequent deproning, his FiO2 always keeps going up. And in the meantime, actually, our team had referred for ECMO. They were reviewing the images and the gases, clinical history. It takes some time for them to review the patient, and if the patient meets the criteria for possible transfer and ECMO treatment. But this is on the day that we again call back the ECMO team. That is after 48 hours. If you look at the pH, it's still acidotic, although we maintain certain level of permissive hypercapnia, but then his PCO2 is also creeping up and up. It is 8.37. I'm sorry, the print is not that great. But if you look at the PO2, it is still about 6.9. And by this time, I'm talking about FiO2 going up to 0.8. Still quite acidotic. Lactates is coming down a little bit to 2.7. So he was accepted for transfer within 48 hours. And on the day of transfer, this is the X-ray. The X-ray is looking visibly worse. This tells us that the reason for his deteriorating oxygenation. So he was promptly transferred. He had lines put in place. The portable ECMO team came. He was put on the VV mode of ECMO on the 28th. He was kept on ECMO for quite a long time, I think almost about a week. Then eventually his ECMO lines were taken off. That is almost about after 10 days. He had a trachea done as well before coming here to our unit back. So eventually he was transferred to our hospital. After coming to the hospital, our unit, back from ECMO, this is his X-ray now. X-ray looks visibly better. His ventilation is slowly weaning. His FiO2 remains at about 0.35. He's doing tracheostomy slow ventilation. His compliance has improved quite well. He's just on PEEP of 8. He's maintaining good tidal volume, good oxygenation. I will look at the gas. So he remains a little sedated, but then once sedation hold, he always command. I think it is at the moment just a slow ventilatory wane and trying to do physios, getting out of that critical illness neuropathies. So his gases is almost normal. If you look at the pH, is normal. His lactates are normal. And this is his, I'm sorry, it's a little faded, but I can tell you that his bloods are almost absolutely normal. So this was a case of young man, severe community-acquired pneumonia, going into sepsis, multi-organ dysfunctions, most prominently the ARDS. We did the usual standard of care. He was brought to the ITU, intubated, ventilated, had to be prone because of worsening hypoxemia. And good thing is that he had probably a better outcome, although he remains critically ill. Back to our unit. Hopefully he will make a steady progress, and we should be able to take him out of the ventilator in coming days or maybe a week. It's coming to a point regarding all our patients, especially in UK. Community-acquired pneumonia remains a big problem. I think this is, I think, one of the recent publications where some of the prominent leaders, they wrote an article regarding the problem of community-acquired pneumonia in UK. They have noted that almost there are 29,000 deaths in the UK, and of which 5 to 15% are hospitalized with CAP, and they have very high mortality and die within 30 days of admission. And they also present, many of these patients are treated in the community, maybe by the GPs or even the wards, But what is noted is that some of these patients might not have adequate antibiotics, some may not be compliant, and there is an increasing concerns about antimicrobial resistance. In a nutshell, it's a big problem even in advanced countries. And while we are dealing with chronic pneumonia, they obviously present with lots of problems. If they are having very severe disease, they are developing sepsis, as probably Aisha has already covered. Sepsis is quite a life-threatening organ dysfunction caused by dysregulation of the response to infections. And this patient we could label as patient going into septic shock, although it's a combination of sepsis and sedation. But clearly, he had a circulatory problem with multiple organ dysfunctions. So this is again a slide I took from ESICM, where they have noted that septic shock can be identified with the clinical construct of sepsis with persistent hypotension requiring vasopressors and lactates more than 2. So our patient clearly was in septic shock with this definition. Now, there are some guidance on how we normally manage community pneumonia. I mean, coming to ED, all these CAP community pneumonia patients will be evaluated for their risk of mortality and morbidity. I mean, we are all aware that we do the scoring system called CRB65, looking at confusion, respiratory rate, blood pressures, and whether the patient is 65 or more. And then we have some other scores like PSI, which is pneumonia severity score. But then recently we have come across a standard called QSOFA, which is a quick sequential organ function assessment. We also gives quite a specific test to identify these patients who are at high risk. We follow the standard surviving sepsis campaign guidelines. Most of these patients, they come with hypotension, tachycardia, tachypnea, looks like quite dehydrated, clinically as well as biochemically. They receive normally fluid boluses, fluid resuscitations, especially in the emergency department. Sometimes we have to carry on doing this even in the ITU. And all our patients receive empiric antibiotics as per our Sepsis 6 protocol that we follow in our trust. And we bring them for further escalations. Most of these patients, if they are scoring very high on this course, will come to the ITU. I'll just skip this. Now, our gentleman that I'm talking about, I did a score of the SOFA. Normally we don't kind of do such scorings, which is good for improving risk assessment. But then we don't normally do it in practice. But many times one can look back at the data and see what is the score for this patient. His SOFA score was 9, which is quite high. And this comes with still a significant mortality of about 33%. So in summary, sepsis is still the primary cause of death from infection. And we are talking about dysregulated host response. Organ dysfunctions many times in this community pneumonia can be occult, but in the patient that I'm discussing, it came very overt, very immediately. Nowadays, all these patients can have different phenotypes in the sense that some patients recover a little early, but some patients might take time. All those infections can have local complications, but can have widespread body dysregulations, causing multiple organ dysfunctions. As mentioned, with the recent papers and articles, the morbidity and mortality is still very high despite quite advances in critical care. I think the only suggestion is we follow our best practice probably needs further studies, help of the governments, improve resources, follow local guidelines. I think with this is the end of my talk. If any questions, I'm happy to take the questions, please.
Thank you very much, Dr. Basamatri, for an excellent talk and presentation of a very complex patient who I think, poses questions about, the management of not only community-acquired pneumonia, ARDS, sepsis, and quite rightly septic shock. Gideon, have you got access to to everybody to see if there's any questions or anyone got their hand up or any comments?
Can you stop sharing your slides?
Yeah, oh, sorry, yes.
Then I'll be able to.
So,
Right.
thank you.
From the chart, I think I'm not seeing. I'm not seeing any question from the chat, unless someone has got. From the chart, there's no questions there.
Just as a starting point, just what do you think were in the management of this patient? Is there anything on reflection and with the power of hindsight that you can see that could have been done differently?
Yeah, Mandeep, I think our team was very prompt in the sense in managing this patient. Now, what we understand is that many patients with community-acquired pneumonia, especially this gentleman that I'm presenting, he is 37. He could have been having community-acquired pneumonia, but very low carb scores. But in him, obviously, the carb score was high. It is like now 3 and 4. He was evidently having raised urea creatinine as well. What I mean to say is that many of these patients might be, in the holding bay or moved to the ward. In those patients, the outcome is worse. But in this gentleman question, actually, he got very prompt attention. He came to the ITU on the day of admission to the ED. After coming to the ITU, he was really given level 3 care because he didn't tolerate high flow nasal cannula oxygen for long. He had to be ventilated quite promptly. And after that, after optimizing all his hemodynamics, ventilations, things were still not working for him, which required escalation to proning. And the moment he is prone, as you are aware, for ECMO, because we understand that the proning is helpful, but then it may not be useful in many patients and might require ECMO service.
Yeah. Absolutely, I think some excellent points there. And I think what both cases have highlighted, the case that we discussed before and the case that we've discussed today with you now, Rupam, is that management of these sick patients really is an MDT approach, and the sooner we can get things done, the better. So early recognition of deteriorating patients, early management, early initiation of antibiotics, and early escalation of very, very sick patients to critical care. Those things really do make meaningful differences to patient outcomes here. Does anyone have any other comments or questions from the shop floor?
I just want to ask. Sorry, I just want to ask Dr. Anupam. I think you told Dr. ECMO. Maybe it's not familiar to most of us general physician. Can you tell us more about ECMO?
Yeah, I think ECMO is now a standard of care. But then when we do referral, I think what we basically do is this patient needs to be prone. Obviously, I'm talking about patient who is going to do ARDS, severe, and then they're prone. Prone is like our last resort of helping with the lung oxygenation, because this is a form of recruitment. After that, we are left with no choice. There's the point where we call our ECMO service through online services, because it is even they ask that the patient needs to be proned. After proning, which is like the best thing or the highest level of optimization that we can provide in our unit, and they will accept. And even after that, when we're talking about proning, we are looking at the blood gases, also whether there's improvement or not. If there's no improvement, of course, the ECMO service is interested. And they have some rule outs, whether the patient fits the criteria, because in the sense when they support, is something like ceilings of care. Will this patient benefit with ECMO? Because ECMO is, in a layman's term, very, very invasive. It comes with lots of complications. Again, hospital-acquired infections, and possibly lots of clotting disorders as well. I'm sorry. Yes. When the patient meets the criteria that this patient can be taken, his baseline is good, he doesn't have too many multiple comorbid conditions, his physiology is good in the sense that he could make a reasonable progress after ECMO. I think in a nutshell, basically, this is how they take the patient. But then to be more specific, they have a very nice guideline on the net. And when we do the referral, there are checklists that we have to fill. So the process is not very complicated for us, although it's quite lengthy. Thank you.
Apologies, Vivian. I'm going to have to hand over to you and Dr. Mohammed to continue chairing the meeting, because I have another meeting to go to. But thank you very much for both.
Dr. Hussein, Dr. Musrat Hussein will take over.
Thank
Perfect.
you.
Hello, guys. Sorry, my
Thanks,
camera is
Miss.
not working. Thanks, Mandeep. So my name is Dr. Hussein. I'm one of the intensive care consultants and the clinical director of urgent emergency at King George's. Thank you very much for a really riveting talk. I suppose from a kind of international perspective, I think one of the things that we're quite lucky is the ability to utilize resources such as ECMO. ECMO is an advanced respiratory support. Question for me, Anupam, what things can our colleagues in Tanzania use when they are faced with patients like this? So basic stuff within the septic patient, and when they breach into the multi-organ failure. So in terms of if our colleagues in Tanzania were thinking, actually, what can we do to improve our patient care significantly? Because and then I can go to one of our colleagues in Tanzania to see actually what is the realistic and what take-home messages and changes in practice that they think can work for the patients across the pond. Over to you, Anupam.
Thank you, Mus. I mean, probably the answer is not very simple. In a sense, I understand that I have worked in very low income situations as well. In the sense, it is a bearing on how we practice. It all depends. Now, that patient might require quite a resource intensive therapies, including advanced mechanical ventilations and ECMO. But in a resource limited situations, usually my hands would be tied, in the sense I would be following surviving sepsis campaign, follow all the pillars, do the basics right.
I can't see my taskbar. All the icons have disappeared. So I don't know where
someone's talking at the back. Okay. So yes, the pillars of management would be following the surviving sepsis campaign, which is very basic. Probably all of us can follow that, except for maybe those advanced interventions. When it comes to pillars of management of all these patients with sepsis and multi-organ failure, it's giving oxygenations, fluid very cautiously, not to overload these patients, and then giving appropriate antibiotics. Now, I know there were some of our panel who were asking regarding antibiotics. Do we follow empirical or specific antibiotics? But in general, the guideline is probably system-based. So we have to follow local guidelines. And now, in this example of patients, if you have chest infections, we have certain set of antibiotics that we will start by default. as an empirical choice, because we all know the cultures which might be available in many situations are, even at best circumstances, are not available for next 48 to 72 hours. Other than that, I think it will be very good if you can catch hold of this patient a little early, because even the patient that I was talking about, he had symptoms for 6 days and he had pneumococcal antigen positive. So he had quite a bad lung, quite an advanced disease. I was just thinking in retrospect whether this gentleman, if he came a little early, he might have done maybe well with just oral antibiotics and need not have come to ITU. So I think in any circumstances, if the people, the patients, our patients present a little early, hopefully they should be able to, cope up with less intensive treatment. But as you can see, this young chap, he would have had a different outcome had we not had this intense therapy and ECMO service.
So there's a couple of questions. Thank you very much. So I think, that's what my take-home message would be as well, actually focus on what's within our gift. So there's a couple of questions. Was it VV ECMO? Yes. It was respiratory ECMO. VA ECMO is predominantly done for cardiogenic shock. How long do you put a patient on prone position, Dr. Basamatri?
I think we do minimum 16 hours. This is standard. But this is not hard and fast. Usually, sometimes depends on our manpower. But usually we thrive to do at least 16 hours of proning. Rarely it could be a little early because it depends on the number of hands that we have to deprone again. But yeah, I would say 16 hours.
Absolutely, 16 hours. I mean, what they find is that actually, COVID, for example, sometimes we did extend because of multitude of reasons. But what we did find was that when we were extended beyond the 16 hours without any significant improvement, it caused more complications rather than actually any clinical benefit. The next question is from Kasim Mawundundi, and the question is, we're curious about the different protocols followed in tackling the same problem, which is sepsis. Point of intervention, administration of drugs would typically determine the outcome of these patients. Is comparative analysis of these variations across geographical regions something that would be of interest to medical researchers? Dr. Basamatri?
I think now we know at least that the patient needs early antibiotics. Now, even the Surviving Sepsis campaign has guidelines that stated if the patient is in shock, we need to have antibiotics within 1 hour. But if the patient is not in shock, in sepsis, or there is ambivalence regarding whether it might be sepsis or some non-infective inflammation, we can maybe just toy around for about 3 hours. But the thing is, I think we understand that if you think it is sepsis and it is septic shock, we just have to give the antibiotic as soon as possible. I mean, with that, I'm not sure whether there are any studies still happening or contemplating in the sense, I'm not aware of that. But then we are following these guidelines in our trust. I think most of us across UK, where your sepsis trolley is present in most of the important locations like ED and some medical acute units, including ITUs. So there is no dearth of availability of the protocol antibiotics that we need to administer. And it normally happens before 1 hour.
So I think in answer to the question, actually, I think it's a question that Prof. Malawa, as the gel between the two areas, may be able to. But I think maybe having a look at what we do within Tanzania and what we do within the UK, because we've got some very robust targets that we deliver. I mean, just to kind of you know, we have reviewed our sepsis guidelines within the trust. The challenge with sepsis, it presents very similar to other systemic inflammatory response, which are inflammatory, and sometimes antibiotics are not the answer. And COVID is a very good example of that. And I suppose, given the emerging resistance of drugs you know, antibiotic stewardship is just as important. So I think this is obviously, I think it'll be interesting to find out actually what are we doing differently in terms of the point of interventions, and does this translate into different patient outcomes? And I think that probably be something that Professor Malawa might be able to kind of take forward, and I'm very happy to support this. Oh, we finally got a hand. Apologies if I do not pronounce this. Julie McCarney.
Hi, yes, this is Professor Julie Makani. So it's great to hear the presentations. Very, very helpful from Zanzibar and the UK. So I have a suggestion that I'd like to make to the presentations, and also to us, the organizers, is that it might be really helpful to have the presentations written up as case reports, and then have case report from the UK, case report from Zanzibar, and then have perhaps a discussion about what the learning was. I think this would be really a really good way of starting to generate and share knowledge, because not everybody would be able to come to the webinar. And certainly in Tanzania, so I'm based in Tanzania, although currently I'm provost visiting professor at Imperial. But it would be something that we can discuss with, for instance, the Tanzania Medical Journal, so that every month when we have these sessions, they're presented. And so I just wanted to check with the presenters whether this is something that would be of interest or value, and how we can facilitate that. So it's less of a question specifically for the cases, and more in terms of a process question or comment. Thank you.
Thank you, Professor Makani. Dr. Basamatri, I think I know the answer, but I'm going to ask you anyway.
Yeah, I think it could be done. Of course.
Absolutely. We're in critical care, and actually we always looking at collaboration. And actually, I think with my research hat on, this would be something that definitely would like to take forward. And I think Dr. Basamatri and I could actually have a look at how we can support this development. Can I ask you a question,
yes,
Professor Makani? In terms of the bridge in terms of practice, what is the major difference, do you think, practice of sepsis per se in Tanzania compared to what we've presented in the UK?
I think a couple of differences. One is that I think in the I'll just switch to my my computer. Yeah, I'm just going to switch off. Hi. So I'm back. Wait, let me just switch off this one. Hello. So I think a couple of differences. One is that, sorry, I just got here. One is that in the UK, a lot of the practice is very much protocol driven from the perspective of either hospital or whatever, and that's not as rigid, not as protocol driven in many hospitals in Tanzania and Zanzibar. So that's one aspect. The second aspect with regards to practice is that availability, as we say, of medicines, interventions, and options. I think that's a second thing. But I think one of the reasons, so I work with Professor Mlawa and Dr. Mwande and other colleagues in Tuheda. I think one of the reasons why we want to have these sessions is that this will allow practice to kind of in Tanzania to become more to learn from the UK. And so even if there isn't something, a particular medicine or a particular intervention, or I heard whether it's to utilize, whether it's ECMO or access to dialysis, etc. These are things that may not be available in some hospitals, but it's something that by having these sessions, it would allow facilities in Tanzania to start developing strategies to get these interventions available. So I think that's the second thing, and then of course in terms of medicines, it's very interesting because I work in hematology, but there are times some medicines are more available in countries in Africa than they would be in the UK, and that has its pros and cons that that we're all aware of. So those are some of the reasons. I think the other aspect is that from a human resource perspective, that's another factor that is different, because having the more human resources, the more people there are, the more detailed the kind of interventions, diagnostic procedures are. So those are some of the, I hope I've answered your question, but those are some.
You have answered the question, and the reason I'm asking that is actually absolutely the education is paramount here. But one of the things that would be really nice in terms of outputs is actually if we could really look at what is it that we could definitely do, and actually how do we support here. For example, we've got bundles here. They're not copyrighted, and there's something that we can definitely institute, and it will mean engagement maybe and education at local centres and task and finish groups within each areas, but one has to start somewhere. And actually, for example, the sepsis is it's the world leading killer, and actually if we can actually turn around and say we can standardize somewhat the approach worldwide to sepsis, which is WHO driven anyway, and share some of what I experienced and what works over here. We might not do the whole sepsis bundle that exists in the UK, but actually even if we can actually do 75% of it, and how we can support over here in the evening to be able to say, well, actually with those tasks, the people from what I know from Professor Malawa, Tanzania is a passionate country that cares about the patients, and they really, really want to improve the care. And that's why we're holding these sessions and this clear engagement. So I think as part of this case report learning, what I would really like to see is actually have some output of it. And it may well be we look at a refined performer or structure with an education and learning structure. And we might start small with one hospital and then sort of branch out. So it's quite exciting, actually.
Great.
Any other questions at all? No, I will hand it back to Professor Malawa to do the closing plenary then.
So I just want to thank everyone who has attended, but also most importantly is to thank the presenters who have done a fantastic job presenting to us two interesting cases, and we've learned a lot from that. And I think this is about shared learning. It's about reciprocal learning from.
Sorry, Professor Mlawa, when you finish your closing remarks, can people switch their cameras on so we could take a photograph for Tuheda?
That's okay. I hope they've had. So I think from my point of view, I'm grateful to both Dr. Aisha and Dr. Anupam for presenting two interesting cases. And I think it's about ongoing shared learning, reciprocal learning. We are learning from each other. I think Mnazi Mmoja Hospital, they are doing a good job in terms of looking after their patients. Can we learn from them? Despite the limited resource, they are doing their best. And from our side, we can also share our knowledge and also learn from each other. And with this, I would say that it's the end of the meeting today, but let us take a group photo for Tuheda.
Prof, come into the room so I can take it with you because I don't have a camera.
You need to be careful what you write. Comprehensive, concise, non-judgmental.
Happy to take photo.
And the same should be back to our objective.
I hope that's taken. Is that okay? What about?
Dr. Nasim, are you taking the photo?
Thank you, guys.
Have you done the photo or not yet?
I have.
Okay, that's okay. Thanks a lot.
Thank you. Bye-bye.
Thank you, everyone.
Thank you. Thank you, everyone.